Welcome, everyone, and thanks for being here. I'm Tarek Brown, President and CEO of CICOA Aging and In-Home Solutions, and I'd like to welcome you to our second Envision Lecture of 2020. The Envision Lecture Series is designed to bring to the forefront issues and trends that impact health and quality of life for the populations we serve. This includes older adults, those of any age living with a medical, intellectual, or developmental disability, and their care partners. Envision presenters are all outstanding leaders in their respective fields, and today is no exception. But to introduce our guest, let me turn the program over to Dustin Ziegler, CICOA's Vice President of Community Programs.
Thank you, Tarek, and welcome everybody. Good morning. As Tarek mentioned, my name is Dustin Ziegler. I'm the Vice President of Community Programs at CICOA. And today we're honored to be joined by Dr. Diane Healey of the Ascension St. Vincent Medical Group. Dr. Healey has provided quality geriatric care to patients for more than 30 years. She provides consultative care in the St. Vincent Center for Healthy Aging Clinic and serves as medical director in several local nursing homes. Most importantly, however, Dr. Healey has been a long-time and dedicated friend and colleague of mine and CICOA. She was 2019 CICOA's Volunteer of the Year recipient, and she's a very valued and founding member of CICOA's Medical Advisory Council. And so today's conversation is about age-friendly care, what it means, why it's important, and how it can enhance health and quality of life for our aging population. Dr. Healey has always been a trailblazer, actually, in this age-friendly movement, and we're excited to have her share her expertise. In fact, one of the things that's always stood out to me is a few years ago, Dr. Healey referenced the state of healthcare that we're entering into as a phenomenon. And when you think phenomenon in today's medical advancements, how could there be any phenomenon left in our healthcare knowledge? But when you think about it, we've never lived this long, and we've never had this large of an aging population. So between the two, it's introducing a whole new concept of care that we haven't seen before, that we've never experienced before. And so now more than ever, with people aged 65 and older projected to outnumber those 18 and younger by 2030 for the first time in our history, now more than ever, it's crucial that we begin to explore and adapt and integrate into these age-friendly models of care with our healthcare systems. So following the presentation, I'm going to share with you a couple of highlights that CICOA has been doing for the request of Dr. Healey to give some examples of age-friendly initiatives with care. And then with some remaining time left, we'll take any questions that we have. So without further ado, let me turn it over to the expert, Dr. Diane Healey.
Hi, my name is Dr. Diane Healey. I am a geriatrician with the Ascension St. Vincent Center for Healthy Aging. And I am honored to be joining you today to talk about age-friendly healthcare 2.0. This is a title really that Dustin, I think, probably came up with. So that means that he's made me start thinking about things that I need to be thinking about in different ways and looking at things differently. So it means that we talk about age-friendly healthcare 1.0, which is where we'll start today. I also want to work on thinking about why this age-friendly influence and the data that comes with it may be slow to get to mainstream, realize how COVID has possibly induced changes to age-friendly care, and let's imagine together what age-friendly healthcare 2.0 might look like. As well, Dustin will describe some programs in which CICOA promotes age-friendly systems. So first of all, before we can really begin talking about age-friendly care, let's talk some demographics. And let's first look at Indiana. So in this particular slide, we have 1970 on the left and 2017 on the right. And we see the aging of the population 65 and older. And during that time frame, obviously, the top category, the darkest red, is the smallest group, yet by the end of that time period, they have increased the most dramatically percentage-wise. That is our over 85-year-olds. They are the fastest growing segment of our population in Indiana, as well as across the country. You also see this little blip in the curve at about 2011, where all of the categories take a higher jump up. And that is the year that the baby boomers begin to turn age 65. So that's the present. What about the future? Well, as we look to the future, and again, this is Indiana data, you see that blue line, which is the 65 to 79-year-old, continues to go up until about 2030, and then it plateaus. And the red line continues, however, to get bigger. That's because in 2029 is when our baby boomers quit turning 65. So that means the oldest ones are now turning 85. So we have a lot of aging people in our society, and we need to figure out how to do a better job of providing care. But this is not just medical either. What do we do to promote quality of life? What do we do to promote health in our communities, in our cities, etc.? And aging is a new phenomenon. If you were born in 1900, your life expectancy was 47. If you're born now, your life expectancy is 78. So we have had a huge change in the last century and a quarter in terms of the ability to age, which means we don't know how to deal with that. We have a lot of work to do to figure that out. And we'll get to that in just a minute, thinking about that. But this is the Indiana data. Here is what happens if we look at the US data. And it's really no different, if you will. It's the same sort of curve that up until now we've been having slow increases since the 1900s of our older adults. But in the future, again, those numbers are going to expand rapidly. We have our baby boomers aging. We've done a better job of taking care of illnesses and getting people through illnesses that they wouldn't have gotten through otherwise, and a whole host of reasons why people are living longer. But this means we need to figure out how to take care of those people and how to do a better job of incorporating them and making use of their many gifts in our society. Worldwide, really no different. The same sort of curve is happening worldwide. And sorry, I couldn't find data that kind of matched the look of the others, except the look that you see is that same sort of, whoops, here we go, 2020 and on up, we're increasing rapidly. So the world has a lot to do to figure out how we are going to care for older adults. The World Health Organization has really been thinking about this for some time now, not that they've necessarily been able to have any huge, pervasive impact for anybody, although they're always coming out with important, helpful information. But if you look at these 8 domains that they consider to be part of age-friendly communities, it really is talking about community sorts of things, which makes sense, because hopefully our older adults aren't patients all of the time. Hopefully they're people, meaning that they are out there making use of transportation, making use of social events and civic participation and whatever you may want to talk about. We need to be sure that our cities and societies are able to accommodate the needs so we can incorporate the many things and the many benefits we get by understanding how to best help and make use of the gifts, as I say, of our older adults. And interestingly, in this list of things, number 8 here is community support and health services. So we don't even really talk about health, if you will, until you get to level 8. And they didn't even really talk illness, they're talking health. So we've got a lot of things for society to be looking at to provide care for these people who are aging, and doing so hopefully as gracefully as possible. Now, fascinating, if you look back to 2006 to 2011 during that 5-year span, and if you go to PubMed, which is published medical journals, and look up age-friendly, there are only 15 citations with the use of that word. That's kind of scary when we see those numbers of people increasing. However, it's getting better. So in the 2015 to 2019, I believe it was 572 articles that at least reference the words age-friendly. That's good. We need all of it we can get, and hopefully that number will increase in the future, that we're paying attention to the sorts of needs that we need to be looking at. But in comes age-friendly health system. So welcome to age-friendly 1.0. Now, in I think it was around 2015, John Hartford Foundation and the Institute for Healthcare Improvement, or IHI, came together and said, boy, we have an aging population. What are we going to do to provide the care that they need? Do we really understand the best way to provide care? We have a lot of older adults out there that are not happy with their medical care. They're not happy with the outcomes. They get harmed by the medical system. Obviously, it's all very expensive as those things happen. So what do we need to do to build an age-friendly system? And this needs to be a social movement. How do we spread this information so we're all aware of it, so we're all able to take part in it, whether we're the medical providers, whether we're the patient and family, whether we're anybody in between? We need a system that is evidence-based, that causes no harm, and is consistent with what matters to older adults and their families. And with this, they said, we're going to put a whole program together. Now, they don't even want to call it a program, a movement together. And we want to make sure that by the end of 2020, that we want to reach at least 1,000 places of care for older adults, so that they've at least added a age-friendly framework to their system. Well, guess what? We're almost at the end of 2020. And so we'll talk in a bit about how they did, or how they're doing getting to those 1,000 places. They're doing well, I will tell you, because they've been extended on their grant from the John Hartford Foundation so that they can keep going, so that we're not done at the end of 2020. They now have till the mid-2023 to reach 2,600 places of care, so that could be recognized as age-friendly health systems. And what does that even mean? What is an age-friendly health system? Well, when these two organizations came together, they said, let's figure out what that looks like. What is that? They brought in other experts in the field of geriatrics to go through literature and look to see what models of care were out there and what was going to be helpful for care of older adults. And what they found was they were able to find 19 different models of care that were all different, but they looked at them to see, okay, what about them is pervasive? What about them cuts to all those different systems to provide the outcomes that they are looking for? And herein lies the answer. It's called the 4 M's framework. Okay, so all these systems had, in their own way, and I don't know that it was even necessarily intentionally, but they were looking at what matters. They were looking at medication, they were looking at mentation and mobility. That's the framework for age-friendly care. If we could all provide this and work through this as we're working with our older adults and their families, we would be doing care that is satisfactory and hopefully above satisfactory most of the time. So we'll talk about each of these just a bit more detail here, the what matters piece. My husband and I have been doing geriatric care for over 30 years now. And the other 3 pieces we really have been doing. That's geriatrics. I mean, that's what it is. We didn't necessarily pull them out like that and specifically talk about those 3 applications, but we were always looking at medications and mentation and mobility. But the what matters piece is a new piece. That piece we didn't know about before, at least to some extent. We were pretty good about asking if they had advanced healthcare directives, but probably not good enough. But for sure, we weren't asking about right now. What's important to you right now? You are 85 years old, for example. You've lived a good long life, which has been your goal, but you're there. So now what are your goals? What's important to you? And what we hear many times from patients is what's important is their family. And what's important is they want to be independent. They want to be functional. Those are probably 2 of the things we hear most, although all kinds of other things as well. And sometimes people just look at it as funny because they've never really been asked before what matters, what's important to them. So that is a vital piece to this whole 4 M's or age-friendly care. Next is medication. Medications are really important. I mean, that is often the thing that has kept people living longer than they might have lived otherwise, is that something about medication at some point in their life, whether it was a vaccination or an antibiotic or whatever other treatment that's allowed them to live longer. But as you develop chronic diseases, you also may be developing more medications, more potential for interactions, and we don't necessarily know whether you still get the same benefits as you develop multiple diseases and as you age, and what these medications do to each other as well as to potentially a frail older adult. So we need to look at medications, make sure that they're still necessary and that they're the best ones possible for that person given their individual situation. We also need to look at mentation and do what we can to promote brain health, but also do what we can to see if there are things we need to be doing a better job of diagnosing and treating. For example, depression. Depression is treatable. We don't want to underdiagnose that because that's a treatable condition. But we also want to be looking for dementia because obviously you need different supports and different care potentially if you have dementia. Or if you have delirium within a hospital setting, we need to understand these things better and the risks that are present with mentation as we get older. And finally, mobility. Mobility is an important piece, as you would suspect, especially because it's one of the things patients comment but most about. They don't say, I want to be able to walk, but they say, I want to be independent. And to be independent, for the most part, you have to be able to walk. It's also a good hook, if you will, that that person who doesn't want physical therapy, yet their goal is to be independent, obviously those two don't work so well together. So it may be your impetus to get that person to do their physical therapy or go out for their daily walk or whatever they may need to be doing to work on their function so that they keep their mobility going, because that's such a vital part of it. So that's our 4 M's. If we can apply those to our older adult patients, we get where we need to. And I could give you story after story of people who we've asked what matters, and whether it's they want to live independently, and we look over their medications and find that there's some changes we might make here that might allow your brain to think a little bit more clearly, may improve on your mentation so that you can also walk a little more steadily and be able to bring in a bit more support in the home and whatever you need to do so that you can reach that goal of being independent, at least for as long as possible. So again, there are plenty of stories out there, and all these 4 M's work together. It's not usually just about working on one of them. They are well intertwined. So this age-friendly health system and IHI, the Institute for Healthcare Improvement, came up with some measures and that they would like to see. And these are all well and good. If we could measure these things and be able to show the benefits of age-friendly systems, that would be wonderful. But I will tell you, it's not as easy as you might think, at least not from our perspective. So one of the things that IHI did when they started putting this all together was they said, we want to engage 5 health systems within the US and ask them to implement the 4 M's at some way or another within their health system, and tell us how it works and what do we need to do so that other people can implement the 4 M's as well. And with that, they went to Ascension Health. And Ascension Health came to St. Vincent because they knew of the Center for Healthy Aging and said, would you work on this project with us, with IHI? And we said, obviously, we would be happy to do that. And so here they have come to us, which we were honored, but we are a clinical setting. We're not researchers. We are not statisticians. So back to that thought on that data piece, that is not something that we do or necessarily have time to do. So that has been a bit of a frustration, and I'm sure within many of the systems to come up with data that IHI would like to see. But when they came to the systems and said, okay, pick out a project, what they were basically saying is pick something you already do in care for your older adults, but now apply the 4 M's. see what the 4Ms does to that work. And so what we did was said, okay, at the Center for Healthy Aging, where we see older adult patients with whatever various medical older adult syndromes, let's put the 4Ms as part of our written report each time. And we do that, and it's very helpful. I don't know that it necessarily changed a lot of what we were doing personally, but the what matters piece again became very important. And I think helping to educate patients and families about the 4Ms becomes very important as well. But we also went to our Medicare wellness nurses who were doing the Medicare wellness visits and said, you know what? The 4Ms are embedded in your information you're gathering on a daily basis. How can we help bring those to the forefront so that we have a snapshot of who this person is, so that we can see what the 4Ms are, so we know if we have someone who is robust and healthy, wonderful. But if we also have someone who is beginning to have a little difficulty or their mobility, or we're not meeting their what matters, how can we work on these things? So our project was to educate the wellness visit nurses and then to revamp their template that they use for their visits and put the 4Ms right there in the front, so that then as the provider, the physician or the nurse practitioner would open up this report, they could see right in front of them the 4Ms. We pulled it out so you could see the score for the mentation on the test that was done, or the score on the mobility for the test that was done. So you could know right up front whether you had something you need to be concerned about. And we thought that that was going to be very helpful and very useful. By the way, for anybody that doesn't know what the Medicare Wellness Visit is, it is an annual visit that Medicare has been paying for the last several years. And it's not a physical exam. It's not your yearly physical. It is a prevention and risk assessment, basically. And so a nurse can do this exam, if you will, but it's not a physical exam. And I find it much more helpful when a nurse does it, because this is the sort of thing they are much more interested in, this information, than possibly the providers. But then they can hand the providers the 4Ms, so that they then have the medical things, if you will, that they can work off of. So what kind of data have we come up with this? Well, I employ someone to come up with an ROI calculator, return on investment calculator, so that you could calculate how many visits you do with the Medicare wellness visit, and then maybe how many times you may have a physical therapy referral or referral back to their provider to work on advanced care directives, or whatever the case may be. So there's a business case for being able to do this. As a physician, I don't really like to talk about business cases, although I am smart enough to know that business does drive what can be done and not done at times. But I'm all about the clinical outcomes and the quality of care for the patients. But that, obviously is an important piece. We were able to come up with a number of patient visits based on this wellness visit exam, the number of patients we see in the Center for Healthy Aging, since we've been using the 4Ms. And this is all fine and great and dandy, but to me as a clinician, it still doesn't, unfortunately, really give me those pieces I would love to be able to see. I go back to that thought, though, that, we are a clinic. We're not researchers, we're not statisticians, et cetera. We are there to see older adult patients on a daily basis. So unfortunately, to have the time to be able to go through all that information and figure out how to get it pulled is not something that is easy to do. What we were able to do, though, is realize we need to keep spreading this information. So the things we're doing are helpful, but not yet enough. We need to keep going. Our work is not over. And one of the things that we realized, of course, up front is just education in general. Whoever will listen to us talk, we're happy to tell you about age-friendly care and the 4Ms, because it is really, really important. It has been really kind of eye-opening in spite of this being what I have done for years. It is just such an amazing way to kind of put a framework around what I do. But we also realized that with the Medicare wellness visit nurse and with the with the template, and then that kind of snapshot, if you will, of the 4Ms, we realized the providers really didn't know what that meant. They weren't necessarily aware of what that fall risk score was, or what the mentation score was, or that they should necessarily act on it even if it was a little bit off, as opposed to being, really abnormal. So we decided our next step from there was to put together a geriatric mini fellowship. So we put together curriculum, a 6-hour curriculum where we will go into a primary care office, and 1 hour a week for 6 weeks, we will do a session with that office on the 4Ms. Those are 4 of the different weeks. And then there's a week on billing and coding, and a week on resources for older adults. And it's not just about going in and talking to the providers. It is the entire office, whether it's the gal sitting at the front desk or the guy sitting at the front desk, whether it's the MA rooming the patient or the nurse or the physician. We want everybody in that room, because we want to hear how they already are doing things with their older adults, and hear what things are going well, and hear what things we might be able to help them look at. We can't expect the provider to do all this work. They need help. So, for example, the person at the front desk, if they're getting the call, 3 times today because the patient's lost getting here and they've been driving here for 3 years, they need to let their staff, their provider know there may be a concern going on. Or if you're watching your patient walk back to the room and as the MA, they're having difficulty getting back there, you need to alert the provider that maybe we have a gauge problem. So we can all work at this together. Anyway, this mini fellowship has been really fascinating. We've done 4 now. We'd completed 3. We were in the middle of our 4th when COVID hit. And with COVID, unfortunately, we had to stop because we were doing these in person. So that stopped for about 6 months. And the 4th group we just finished 2 weeks ago. And unfortunately, it had to be virtual. I mean, that is better than not doing, although in person still provides just kind of a different milieu. And a different kind of enthusiasm. And I think when we're there in person, then the whole office can really talk together more easily. But we will hope to continue to do more mini fellowships. Again, problem is, how do we get data? How do we figure out how this is helping anything? It's obviously very labor intensive. We've also added, to spread this further, a team within the hospital. So we have a nurse practitioner who does inpatient geriatric consultations, which are primarily related to mentation and mobility and medication. And she does these in a 4M format. So that has been very helpful as well, and another way to help spread age-friendly care. Again, we always want to hear about data, and there was an article in the Journal of the American Geriatric Society just this past 2 weeks or so, and within that article, you see a little bit of data that they are talking about, and Dr. Fulmer was one of the really initiators of the whole age-friendly project, and so we see a couple different places that have quadrupled advanced care directives. Ascension, they quote in this article, as having increased our wellness visits, meaning those people were touched by 4Ms, if you will, although again, I need to make sure now someone knows what to do with that information. And Stanford, who has had some increase or decrease in direct patient costs because of work they were doing with their trauma service. So some good things are out there, but again, hard to measure. So why has this not taken off better? In response to that Journal of American Geriatric Society article by Dr. Fulmer, there's an editorial, and the author suggests that we need more administrative buy-in and commitment, continued access to resources, clear champions. This needs to be part of a public health system. And so my guilt for, why we don't have more data, why, can't we show these things, really here's a big part of the answer. So it's not just me and us. It's, I think, everywhere. It's a potential problem. Unfortunately, COVID has not helped that. Anything that I just mentioned on the prior page as a potential pitfall is now probably an even bigger concern in terms of getting to where we need. I just threw this in because it's COVID time, but interestingly, the age group that is more likely to get COVID is the 18 to 64-year-olds, but unfortunately, the death rate in older adults who do contract the disease is much higher. So the upswing to COVID may be some changes more quickly in care that we are providing to our older adults and systems that we use to look at what care is available and what systems are in place for our older adults. So back for a quick minute on IHI and how they are doing with their age-friendly care. They are up to 847 participants and 185 committed to excellence, meaning that there are 847 groups out there that are looking at 4Ms and have written a plan how they might implement, and 185 who have actually have some data, at least to show things, some data on some of the things they're looking at. So they're reaching that 1,000 they've reached it really by the end of the year. And this numbers were back from July. So we have this tiny little piece here, age-friendly health systems. And that's what I've been talking about, but it's a tiny little piece of it. And this now kind of refers to that article that Dr. Fulmer just published. And we really need to now look at this in even a bigger way. We need to look at age-friendly ecosystems, because the health piece by itself probably isn't enough. What happens out there in our cities and our states? How can universities be of help from either research and teaching to their students, but how can older adults make use of universities and continue to improve their knowledge as they want to on whatever topics? And again, public health needs to be an important part of this. Advocacy needs to be an important part of this. There's places for all of us to work within this system, but it all needs to be seamless, and we all need to work together so that everybody knows, has a means to know what else is going on out there. And that is the difficult part, to know what other people are doing and how do you access all this information at once and easily. Also within the last couple of weeks, there was an article published in the New England Journal of Medicine by Dr. Linda Freed, who has been doing a lot of geriatric work over the last 30 years. And she, the listing on the right here are the things that she talks about in the article that are really important to the future. And it's fascinating because when you look at that then next to the ecosystem from Dr. Fulmer, they're talking the same things, okay? So these are the things that we need to be looking at and thinking about in the future, and finding ways to, help be sure that what we have available for our older adults and for those of us as we age, that it is an age-friendly ecosystem. What can you do? Well, if you are within a healthcare system, you can join the movement. Again, this age-friendly care, they wanted it as a social movement. And so I'm not really here as an infomercial for IHI, but I am. I mean, I believe in the work that they're doing. So they work on action communities, meaning they had those first 5 pioneer programs, but they bring others on board through these action communities, which they do a couple times a year with pretty intensive education, help you work on a project, figure out what it is that you might want to do within your system to apply the 4Ms and how to implement that. So that's been very successful so far. Again, data is kind of hard to come by, but it's the right thing to do. And I think places on their own are coming up with data that is important. These other ways of participating are if you, just on your own have something that you're working on and you might just apply these 4Ms without it being a bigger deal. You could do that in terms of some participation, and they have on their website ways in which to do that. And the scale up would be for a bigger hospital system that wants to scale up quickly. I do find in terms of the data that now that academic systems are becoming involved in this, we may see more data because that's what they're used to doing and that's what, they are set up to do, is to, come up with hypotheses and, do their research and come up with information. So I feel that we may see more of this, but some of it has to do with find what works for you. What works for you may work for the next person, but they may, have something totally different that works for them to make their system age-friendly. Another way to make systems age-friendly is, again, making sure we're talking across the silos, if you will, so that we all understand what each other's doing. And we've had the time to do that and the ability to do that over the last couple of years. with Dustin, coming up with, a great idea of having the St. Vincent medical residents spend a little time with CICOA. So since January of 2018, through now, we've probably had about 72 residents who have spent a little bit of time with CICOA, getting a better understanding of what they do. So all of the medical residents at St. Vincent, the family medicine and internal medicine, are required to spend a month with the Center for Healthy Aging, learning about geriatric care. So first of all, they do learn the 4 M's. Whether they remember, it's another story, but they do learn it. But one of the sessions we have them do during the month is with CICOA. Pre-COVID, they would actually talk with Dustin for a little bit and learn about CICOA, and then they would actually go do a half day doing home visits. They were thoroughly enjoying it and learning a lot by just the firsthand experience of being there. Of course, since COVID, they now just get virtual time with Dustin, which I'm sure is wonderful, but is probably not quite the same as being out there in person. But I know that they are still getting a lot out of it, and it's important that we all understand, how, what of our patients might benefit from services that are out there, and knowing what services are out there. In just a minute, Dustin's going to talk to us about Dementia Friends of Indiana and anything else he might have up his sleeve, as we need to begin looking more at age-friendly cities, age-friendly states and communities, as he's already done an amazing job with the Dementia Friends, but I'll let him talk about that in a minute. So what do we all need to be doing? We all need to be being champions for this, finding ways to implement this, be innovative, collaborative, communicate, educate. The more of this that can go on, I think the better chance we have of improving the speed of which this social movement occurs, so that we can see results that are important for our patients, for our families, for ourselves as we age. Well, thank you for your attention. I am going to turn it back over to Dustin at this point, and we'll be happy to talk to you further in just a bit.
Thank you for your insights, Dr. Healey, and the great work you've done advancing age-friendly in the 4 M's. I can definitely say I'm hearing our local health systems talk about age-friendly and the 4 M's way more now than they even were 3 years ago, when they talk about their strategic planning and their future of their systems. So very encouraging, and it sounds like we're going in the right direction at least. So thank you again for your great work. With that said, Dr. Healey asked that I highlight some of the related work that we've been doing at CICOA as some examples of how the current and evolving state of healthcare and age-friendly systems is coming together. So there's numerous highlights that we could share. I'm going to touch on 4 just to give kind of 4 concrete examples so that you can take these concepts and identify ways that you can implement them on your own, regardless if you're a healthcare professional, a member of the community, or anybody in between. So the first one I want to highlight, Dr. Healey mentioned our partnership with their geriatric clinic in the St. Vincent Center for Healthy Aging. Family medicine residents doing their geriatric rotation, part of that is spending some time with CICOA to learn not just about our resources, but just as importantly, about all the numerous factors that go on and influence health outcomes that happen outside the clinical setting. So, in medical school, in residency, we learn about pathology, disease management, medication, et cetera, a lot of clinical application things, but not a lot of how does the outside world play into what goes on in the clinical setting. So for example, you can have the best doctor in the world prescribe the best medication, but if you don't have transportation to get there or to get to the pharmacy, what's that matter? If your caregiver, your loved one, doesn't have the caregiver proficiency to take care of you, that will greatly influence your health outcomes. So with this experience, these residents, sometimes for the first time, get a very real-world glimpse into how the care that they provide, particularly the geriatric patients in the clinical setting, translates to what goes on in the home setting and the barriers that can influence that. And so through this partnership, these young future physicians get a real-world example of how medicine and health outcomes and their role is about 20%, and 80% of the health outcomes is everything else that goes on outside those 4 walls of the clinical setting. And so they learn that it takes the whole village to optimize health outcomes, and they're able to apply that in the real world as they continue to enter into their career. So crucial experience, mobility issues, what goes on in the home, fall risk, transportation, the whole 9 yards, that 80% of health outcomes that we refer to as social determinants of health. That's the experience these residents get. So really important, really impactful partnership we've had with Dr. Healey and the residents, and looking forward to the future, particularly as COVID begins to hopefully wind down and we can get these residents back in the home. The second one I want to highlight is a program called GWEP. It stands for Geriatric Workforce Enhancement Program. And this is kind of similar to what Dr. Healey, I think, referenced with kind of like a mini geriatric fellowship type of program. The GWEP program here locally through Eskenazi United School of Medicine, CICOA has been very involved in that. And when Dr. Healey was talking about the entire clinic being age-friendly, not just the physicians and clinical practitioners, but the whole clinic, and why, that's what GWEP is. We're educating future practitioners, current practitioners on geriatric medicine aspects, so that when they are in the clinic, all those considerations that go along with geriatric care are factored into their care, and they get the education and resources about community resources, what's out there, how to gain wraparound services to improve outcomes for this really complex geriatric population, how to identify and talk with somebody with dementia, how to look for depression, et cetera, et cetera. So we have one here locally, as I mentioned, and then one with our friends down in Evansville at the University of Southern Indiana has a GWEP program there too. So another crucially important program that's preparing our future geriatric practitioners for the work that they'll be doing. A third one, which is big for me and the future of CICOA, is contracting with our local health and hospital systems. We talk about age-friendly hospitals through this lecture. CICOA has been gradually working to collaborate more with actual health systems in the care of the geriatric patient population that they see. So we've been doing more and more contracting with health and hospital systems to provide care transitions and optimize health outcomes upon discharge to the home. And a really strong component of that is one of my favorite statistics about CICOA. On average, somebody who would be eligible for nursing home care today is able to remain at home and independent and in their community for about an average of 3 years, as opposed to an institutionalized setting. So when we partner with these health systems, we're able to keep these patients in their home where they want to be, in the best care at lower costs too, which is a great partnership with the health system. So together, that whole village concept with this patient population, it takes a village, and so we're partnering more with health and hospital systems and are looking to expand that, where we actually have CICOA embedded in these clinical settings to streamline access to resources to optimize health outcomes. So that's another big one. And then finally, Dr. Healey mentioned Dementia Friends Indiana. And if you haven't heard Dementia Friends Indiana, it's actually pretty simple in concept, but hugely impactful in application. So the core mission of Dementia Friends Indiana is to better educate our communities just simply about what dementia is, reduce the stigma, and then take actions to create more welcoming and conducive environments for those who are living with dementia in our communities. This is the largest disease, most complex, most expensive, and it's only getting bigger and bigger. And so our communities as a whole are going to continue to have to create more conducive environments for the rapidly growing volume of people affected by dementia in our communities. And so Dementia Friends Indiana seeks to do that. It's a grassroots, community-driven campaign. And the fun part about it that we like, if you haven't been involved in it, and we encourage you to do so, is the take action part. So you don't just learn about dementia, you become a dementia friend, and then you're tasked to take action to do something in your communities, however large or small that may entail, whether that's reaching out to your local church, to a business to make them more dementia friendly, et cetera, boots on the ground in your communities to improve the lives and well-being of those affected. Never in our wildest imagination would we think that what we've done with Dementia Friends Indiana in 3 years would have the impact that it's had, but we've gone all the way as far as to make it a statewide program with all area agencies on aging in Indiana now leading it in their local areas. Over 7,000 dementia friends, and large scale successes and outcomes too, particularly just a few highlights. A shout out to IU Health Saxony. They're the first Dementia Friends Indiana hospital who hospital-wide, every single employee becomes a dementia friend. And the purpose of that is that when you walk into the hospital, it doesn't matter if you encounter a nurse, a doctor, a cafeteria worker, maintenance, you know that when that person encounters you and your loved one with dementia, you know that it's a safe and welcoming environment. Their culture has been implemented to be that way, and that person knows what you're going through and can better communicate with you no matter who they interact with. And so this is a hospital-wide program that I think could easily be replicated across all hospitals in Indiana and maybe even the nation. And we've seen some remarkably good outcomes with it so far, hugely receptive. And we are doing a little bit of research to gain outcomes to show evidence to its impact. So you could be seeing more of this down the road. And we do have another handful of hospital and health systems you'll be hearing about soon who are also coming on board to become a Dementia Friends Indiana hospital and health system. So that's just one area, Dementia Friends Indiana. We've partnered with even first responders, Department of Homeland Security. Thank you to Dr. Michael Kaufman, head of the International Homeland Security, to implement a training program under Dementia Friends so that all the first responders have that education about dementia when they interact with somebody to improve health outcomes. And just many, many, many more. But you don't have to, you don't have to create an entire statewide partnership with Homeland Security in your role. Those are kind of some of the big highlights, but you as an individual, as part of the movement, can get involved. And like I mentioned, just learn about the movement and then go out in your community to get more people involved with it, create more dementia-friendly environments and communities, and help us continue the advancements in Indiana, making us the most dementia-friendly state in the United States. And so to learn more about that, it's just dementiafriendsindiana.org. And we'd be happy to have you on board and continue the exciting momentum with the movement. So those are four current and evolving examples of how we were looking to improve health outcomes and just the general state and well-being of older adults in Indiana through age-friendly, not just healthcare systems, but just in general, because one leads to another. So with that said, I thank you all again for your attendance and hearing us and learning about the 4 M's and age-friendly and the future of it. And so with that, I think we have time for a few questions. And so we'll turn it over to questions, and we'll see you next time. Thank you. Dr. Healey, good morning.
Hi, good morning, Dustin.
Thanks so much again for your expertise and your time. We always appreciate it. You know, we joke that you're semi-retired, but we keep you probably busier than ever. So as always, thank you.
That's right. Absolutely. No, I appreciate it. You know, and again, I think, you know, your words here at the end, Dustin, were, again, it highlights the importance that this is, you know, it's a whole system issue, which means it's also a system solution. So it's not just, you know, me working in my silo and you working in your silo. It's how do you cut across all these, you know, all these areas to make it all work. I mean, those social determinants of health play such a huge role in this whole piece. And again, you know, I also talk about person-centered care, not patient, because when you are in the doctor's office, fair enough, you're a patient. But when you're at home or you're trying to go out to a restaurant, if we can do that nowadays, if you're trying to do whatever, you want to be a person. You don't want to be a patient. So what do we need to do for our communities and our cities so that all that can happen?
Absolutely. Person-centered versus disease-centered, as I learned from you a few years ago. So
absolutely.
We got a few questions for you as we wrap up here. And if we don't have time to get to all of them, I think we can shoot out some answers later for everybody. The first one is a question for me. So I know that you and Mr. Dr. Pat Healey have spent quite a bit of time. You're very well traveled, and I believe you did some work and some training in England, geriatrics. With your experience in England, how does that compare to the United States these days when it comes to these very things that we're talking about, age-friendly, social determinants? And do you see the United States moving in that direction in any capacity going forward?
Good question. I mean, England has a totally different health system than we do. You know, they are socialized care, socialized medicine. So everybody gets care, and it's not just about acute conditions. So, you know, they have been dealing with these issues for a lot longer than we have, and have done a better job dealing with them because they are working to keep people at home, and they are working to keep people active in their communities. So they, for a much longer time, have worked on this. The whole 4Ms piece, again, that's kind of new in the last couple of years, but it has been taken to other countries as well, because even though, you know, there are other countries such as you know, England, who have been dealing with this and probably doing a better job for longer, we still all have room for improvement. On the other hand, we can't just pick up what they do and bring it here, because our healthcare systems and our cultures and what matters to everybody are so different. But I think we all have things that we can learn from each other.
Sure. Thank you. And I love the fact that we consider this a grassroots, kind of a social movement, kind of like Dementia Friends. I love that component of it. I think sometimes taking that angle can be more effective. And just real quickly, you mentioned universities, maybe universities can get involved. And so I happen to know that there's a few university representatives that attended today. So keep that in mind if we want to explore some data as it relates to this. That's so crucial. Kind of a question I expected, but also kind of a tough one. When we talk about this with payment models and kind of incentives to expand this and make this successful, have you seen or do you have an idea about the trends with insurance companies or others who hopefully when the data is there might lean towards more incentives to take on this type of model of care?
You know, you're now asking political questions, Dustin, because all you have to do is talk about, you know, healthcare and, you know, Affordable Care Act and Obamacare, and you get all the different sorts of responses from people. What I will tell you, though, is that to provide the kind of care that our older adults need, fee for service, which is what we have, you know, had in the United States traditionally for years, it doesn't work very well, because the whole model is based on me doing something for a patient and getting paid to do that. And, you know, so, you know, in our current model of care, although we are getting more situations where you have advantage plans coming in, which may or may not be beneficial depending on how they are being set up. But, you know, we need for the system to not pay for everything that is done, because unfortunately it's humans who work, and therefore money comes into play. But if we can, you know, have the system set up so that you are reimbursed to save the system money. So, you know, right now the system gets more money for every CAT scan I order, for every, you know, test I order, for every, you know, whatever I do. It doesn't necessarily, although some aspects are starting to, it doesn't necessarily save anybody money that they can use for something else if I worked hard enough from keeping someone from being hospitalized. Or if I worked hard enough to keep someone in their home and not need a nursing home. I mean, the system is just kind of perverse incentives for how it's done. So we've got a long way to go as far as our healthcare system in order to make, you know, an age-friendly system work most efficiently.
Okay. Yeah, and I think we've seen a lot of positive, or at least optimistic trends with value-based care. And I did mention, I mean, in just the last few years, I hear more than ever 4 M's, and it may not be 4 M's as in that's their number one priority, but people are at least talking about it at the executive and clinical.
Good. And again, you get around more than I do, so that's awesome. That's great to hear that. So that's
yeah,
wonderful.
Absolutely. And I mean, just the fact that people know 4 M's, I think, is a whole revolutionary thing. So kudos to you to be in the rock star trailblazer to get that going. Another good question from our attendees, baby boomers. So you've been practicing for a good while. You have a lot of experience. How have you seen with baby boomers? Are they a little bit more proactive with their healthcare, do you think, than you've seen in traditional generations?
Well, I mean, again, very individualized. You have some of those people that, aren't going to exercise. They're never going to exercise. On the other hand, I think overall, yes. I mean, we're seeing people being more proactive with their health. Not everybody, but more being proactive. So more exercise. And, if you think through the things that all of us should be doing for our health, it's physical activity, it's exercise. Okay, that's probably the most important thing we can do. Next is being socially active and engaged, keeping that mind active. And I think that there are plenty of people doing that. It is a healthy diet. Those are things that all of us can be doing to be proactive for our future, for our healthcare. I also feel like, though, that we are seeing more people who, are concerned, though, about their mentation. Do I have dementia? So we are seeing people earlier who are concerned. And I think it's because of, being more attentive to what's going on around them. We also have more, I think, that are being more concerned about, where they might live in the future and, what sort of, housing might be, where they go to next. So yes, I think slowly but surely, things are changing, hopefully for the better.
Good. And that in and of itself, I think, is encouraging when you mentioned you're seeing more people coming in about their concerns with cognitive capacities and stuff. Still a long way to go, but I know just in my career, one of the biggest barriers is just, denial and just getting yourself or a loved one into the doctor's office to get that diagnosis and subsequent earlier intervention. So hopefully to work through things like Dementia Friends and other things to provide more education and stigma reduction is starting to pay off a little bit.
Right.
I think we got time for one more. So let's see, which one? Oh, you mentioned, so there's, I think 185 systems right now that have at least some type of data. Do you know if that is housed in one spot or if that is accessible?
I don't think it is. I mean, I think it's that each of those places have a little piece of something. I would suspect, has that, but I don't think it is published data that is available to everybody. But that is one of the real frustrations. I can tell you that what we're doing is the right thing, but I can tell you stories, but I don't have numbers, to show you. And we need numbers. So, it probably is going to, I would suspect more come from academic settings where that's what they're set up to do. They're set up to, ask the right questions, have people available to get the measurements and to, do the statistical analysis and do the things that need to happen, because, that's what people want to see, to a large extent. Having said that, providing the age-friendly 4Ms framework of care to our patients, I can tell you that, again, plenty of stories who individuals are thoroughly thrilled with being able to express to us what matters and us looking at, and Dementia Friends actually is a perfect example, ask what matters to people. And a lot of patients and families want to be able to get out and to do things. So that Dementia Friends allows people, to take their loved ones out because their mentation doesn't allow them to do things like they would have otherwise. It promotes mobility because they're out and doing things. And, ideally, I guess the medication piece is a stretch to throw that in there, but someone hopefully is looking at that. But, it's programs such as that, though, that allow us to, bring that 4Ms into play and have good stories. I don't have data, but I've got stories for you.
Sure. Yeah, that's great. Yeah, data is all, and we struggle with data too. That's probably our biggest barrier. Just like you mentioned, we know that this works. We know that outcomes and interventions are going to be better, but sometimes it's hard to provide that. You mentioned the Dementia Friends. That brought me to an example too. So we are hosting what's called a memory cafe right now at UIndy in partnership with their School of Music. And so just the other day, they were out in the parking lot, social distancing, but we had people dancing, couples who got out of their car and they were dancing to the music and moving around. And so, it's just those little things.
Yep, that's awesome.
It makes such a huge difference. So got basically one more minute. Do you have any final parting messages or words for us? Sure.
I'm always happy to talk. For those of you still, on and listening, I mean, this is something that anybody can take part in, no matter who you are, what you do. So, I'm not part of a healthcare system or whatever, or I don't feel like I have a ability to make change or things happen. You can apply the 4Ms to anything you do. And that was one of my amazements when we, started doing this. I was kind of like, we're not a research place. We're, whatever. You don't have to go reinvent the wheel. You don't have to go start something new, but think in your own life, even if it's for your own parents or for yourself. Go through the list of the 4 M's and figure out, what do I need to do to, help make this happen? And it might even be that you're the one asking the questions when you do go to the doctor.
Oh, sure.
Because your own provider might not really understand this yet or know about it yet. So maybe that's how you're promoting this. And, it's just for yourself. If it's not even in a situation that you might be otherwise, where you can help promote 4M. So we can all be champions for something or somebody.
That's perfect. To end it. I love that, because, as we know, the biggest advocate, the biggest person most responsible for your healthcare is you.
Absolutely.
Your doctor or your nurse, but you. So
absolutely. Yep.
Well, thank you again very much, as always. We appreciate it very much. And
sure.
I'm sure we'll be in touch with you soon.
Good. Great to see you, Dustin. I don't get to see you enough.
I know. We got to get COVID out of here.
I know it. You got it. All right. Stay safe, everybody.
Thank you. Bye-bye.
Bye now.